We're right at the 6 o'clock hour. So we'll get started. Thank you, everybody, for being prepared and signing on ahead of time. It's wonderful to see so many interested folks here tonight. And we've got a plan for you all tonight and for our time together that involves a lot of time for your questions and also some time to get to know our program. So I think what we'd like to do is just start with an introduction of the Dartmouth Hitchcock Medical Center folks and the fellowship program folks who are here tonight and who you'll hear from. So we'll start with that. We'll give a little introduction to our program, and then we'll do some introductions from you guys as well, from the people attending. So I'm Amelia Kerner. I am a PA. I work in the medical ICU, and I'm also the program director for the fellowship, which you guys are all here to learn about tonight. And I just really want to say again, this is a really exciting night, and it's an exciting time as we think about recruiting for and welcoming our incoming class that will start in the fall. And we're just glad to have you here and excited to answer your questions. So Matt, do you want to introduce yourself next?
Sure. My name is Matt Raczynski. I'm the medical director, and I work at Dartmouth in the medical and surgical ICU and the ED. And I've been, I guess, with Amelia since the start of the program.
Awesome. And Sam and Ellie, how about you guys?
Everyone, my name is Sam. Can you hear me? Yeah, okay. Sorry, my name is Sam. I am one of the nurse practitioner critical care fellows. I previously worked in medical ICU as a nurse prior, so this is a new role for me.
And I'm Ellie. I'm a PA, one of the critical care fellows, and I just finished PA school in August, and this is like my first job out of school.
Awesome. Thank you guys so much for joining us tonight. And just for a little bit of context, I think Sam and Ellie are both in the first few months of their time with us here, and can tell you guys a lot about the process because it's all fresh in their minds. Great. And Holly Ann, do you want to go next?
Yeah, sure thing. I'm Holly Ann Kramer, and I work in workforce development, and I help to manage the recruitment for the Critical Care Fellowship Program here at Dartmouth. I've been working with this team for, I think this is my third year now, so super exciting to see all the faces over the years. And I am joined on the call tonight by two of my colleagues as well. So Bailey Hansen, whose name you've probably seen a couple times now. She's the coordinator on our team. And you'll see her name again pop up in email through the process. And then also Jenny McCauley is on the phone too, and she has been around since the inception of the APP postgraduate programs here at Dartmouth Hitchcock. So she's our manager and helps in the space as well.
Fantastic. Thank you guys. What was that, Holly Ann? Sorry, I cut you off.
Nope, I just said it's great to see you all tonight.
Yes, and you guys do so much behind the scenes to make the program what it is, and especially in this part of the process. So it's exciting for all of us here. Great. Well, so with that, I'm going to share my screen, which means I'm not going to be able to see you all. So feel free to just speak up if something is not right. And we'll just go over just a basic presentation and information about our program. Hang on a moment. It looks like, just give me 1 second. It looks like I lost the PowerPoint that was up. So I'm just going to pull it up again, and then I should be able to share it. Always gotta test our video meeting skills here. Okay, So there's that. And then let me put it into presenter mode so that the view is better for all of us. Okay, how does that look, Holly Ann? Is that looking good?
It looks like we're only seeing part of your screen for some reason, but maybe
Oh.
that's just me.
Anybody else having that as well?
Yeah, it looks like it's like the top corner of your screen or something.
Zoomed in.
Yeah.
Oh, dang. Okay. Let me stop sharing. And
If you
exit out.
present first and then share the screen that it's presented on, if that's possible. I don't know if you're just on one screen.
Oh, sure.
that
Yeah, let me
usually
try
helps.
that. You see, I'm not sure I can do that because I am just on one screen.
Yeah, it's tough when you're on one screen, unfortunately.
Yeah. Okay. Let's
Maybe
see.
just try again. It worked earlier, so
Yeah.
it's been a fluky share.
I think you might have to share before going into present mode on PowerPoint, maybe.
Okay, let's try this. Okay, how's that?
I see the whole
Oh,
screen.
we can. Yep, we see
Okay.
your. Yep. So try to press present, and we'll see
Let
if
me
it.
hit present mode. How does that look now?
Much better.
Oh, good. Okay, great. Well, here we are. This is our landing page for our information on the APP Fellowship. And what you're looking at there are two of our transport helicopters and the main campus where you would do your fellowship and spend all of your clinical time. We're located in Lebanon, New Hampshire, which is really right on the border of Vermont and New Hampshire. Dartmouth Hitchcock Medical Center is a tertiary medical center. We're the only tertiary medical center in New Hampshire, and really cover a lot of Vermont too. So a lot of our critically ill patients come in as transfers. Over 50% of them come in as transfers. And these helicopters and a lot of ambulances, both local and associated with Dartmouth Hitchcock, bring our patients in. And then we also have an ED and a large kind of floor patient population where our critically ill patients come from as well. It's a beautiful hospital. It's a beautiful place. It is cold in the winter, but there's lots of fun to have during this season as well. And so yeah, this is it. This is a good representative picture of what things are like. This is just an overview of our night, which we've kind of discussed already. We've done some introductions, and we're excited to hear from you all about who you are a little bit. This is the part where we're talking about critical care at Dartmouth Hitchcock and the fellowship experience that you guys are all here to learn more about. And then the bulk of our time is going to be spent doing question and answer, which I think is hopefully the most useful time for you all here. And in the picture, we have one of our physician fellows actually who is helping us with a sim. I believe that's actually Morgan, one of our SICU APPs, donning sterile garb there. And then two of our fellows from 2 years ago cohort now participating in the sim. So that's the picture that we've got for you on this slide. You have already heard from me and Matt, so we'll go right on to our residents. And you have Sam and Ellie, our newest class of residents, live on the screen for you all tonight. They are our fourth cohort. These are our three past cohorts. And we have been really fortunate to train some fabulous both APRNs and PAs, and all of whom are represented here in this picture, and are, really near and dear to our hearts because we've spent a lot of time learning and teaching one another. So those are our past cohorts. Always fun to see them. And then critical care at DH. Just talk a little bit about critical care in general and also what it's like to practice at Dartmouth Hitchcock Medical Center. I think, critical care is a really exciting field. It's gotten a lot more press over the past few years with the pandemic and the ways that those critically ill with the pandemic have been treated. So I think a lot of you have had maybe more exposure to what critical care is than some of our first applicant pools. But it's certainly my passion in medicine is critical care, and I feel really privileged to have found an area of medicine that I do love so much. I think one of the things that I appreciate most about it is that it really gives you a chance both to have the skill set of how to kind of act quickly, make decisions, be hands-on, and do some bedside procedures, while at the same time really testing your physiologic knowledge, kind of digging into some more challenging, both physiologic and pathologic questions in medicine, and also some ethical challenges as well. So it really kind of runs the gamut in terms of the skill set. It is fast paced, but there is an ebb and flow to the work, which is different from an outpatient setting that I also really, really do appreciate. And so you kind of need this dual skill set of how to have really close attention to detail, take care of critically ill patients over a long timeline, while at the same time gaining this acute stabilization skill set that you need when your patients are acutely decompensating. And these are skills that we aim to teach you in the context of the fellowship. And I think the other thing that I really appreciate so much that's represented in some of these photos here is the team-based nature of the care. So I'm definitely just really somebody who is my best self and is really inspired by working with the team. And the critical care team extends really broadly. So you have your kind of insular team, which for us is an APP, a physician fellow, an APP fellow, an attending physician. And then the team really broadens out from there to your bedside nurse, all of the nurses on the unit, and then all of the support services that take care of our patients as well. And sometimes that includes consultants from multiple specialties, physical therapy, occupational therapy, speech and language therapy. So just a really big team that contributes to the care of our patients. And in the APP role, you're often coordinating people on all of those levels. And it's that in itself is a skill set and a really satisfying role. So at DHMC specifically, we're really fortunate to have APPs working in all of our critical care units. So we have in the MICU, we have a critical care team that's all APP based, that splits their time or splits the medical ICU census. On the other side, there's an internal medicine residency team. And in the surgical ICU, we have APPs working embedded in the teams there. The neurocritical care team has an APP based team that's doing a lot of the care there. And so I think one of the reasons why we decided to start and grow the critical care fellowship at DHMC was because we had such strength in our APP practice in critical care. So it's a real advantage and something that we're really proud of and continuing to grow is the APP practice in critical care. So we'll move on now to talk just a little bit more about postgraduate training that is involved in the fellowship. These pictures here just show some of our teaching didactic moments. So on the left are two of our respiratory therapists who are also trained as ECMO specialists, showing our fellows the ECMO circuit, and we're doing teaching on that in this photo. And then on the right is Amanda, one of our prior fellows, working on one of the ultrasound trainers practicing placing a central line right down on the unit. And this was something we did as one of our didactic sessions as well. So our goal is really to prepare really clinically outstanding APPs in critical care. And APPs who are really confident and capable being members of a multidisciplinary team with a really high degree of professionalism, competency, and curiosity. And that is what we are looking for at the end of our 12-month program. And we're really, hoping for people who are excited about growing themselves professionally, both in the skill set and in just sort of engagement in this area of specialty as well. And we do that by providing a really hands-on curriculum that balances a lot of clinical time with a systems-based didactic curriculum. And Matt's gonna talk a little bit about our curriculum.
Yes, I think there are two parts, and the goal is to transition out of student mode into provider, where you're kind of doing the thinking and doing the hands-on. So the clinical aspect of it is having our kind of core critical care rotations are in the medical, surgical, and neuro ICU, with exposure in the CVCC, where there's a kind of a graduated progression of taking on a few patients and more responsibility, where towards the end, hopefully you're a kind of an independent member of the team where the kind of supervising APP is not even needed. Now, with that said, the goal is for your education, when we're trying to think about balancing the educational workload versus the service workload, and really tipping towards the having the education and the backup to make sure that you're not just carrying out tasks, but learning to step into that role and make medical decisions. And I think one of the really nice things, even our first year of doing the program, when the beginning of the pandemic, was having our fellows be able to transition into that kind of provider role to help the team when we were trying to figure out how to provide care as we went along, like everywhere in the country. So break this down with clinical roles in the mainly ICU based, and then having skills rotations with rotating with anesthesia to get better with airways, interventional radiology to get more experience with needle point localization, chest tube placement, central line placement, palliative care. It's a big part of what we do on service every day. And then having some elective blocks to choose from, which, depending on your background and what your individual interests are, some people are interested in more cardiac things. Some people are interested in broadening their infectious disease, interventional pulmonology knowledge, rotating in the emergency department. And it's kind of a choose your own adventure of, where do you think you might want to go and have more experience. Now, along with this, there's a didactic curriculum, which kind of runs independently, because both of our fellows are on kind of slightly different schedules. We have a systems-based practice model where the first month is really getting the foundational skills of, what is critical care? How does rounding work? What is sepsis? How do I work in the NICU? Basics of acid-base physiology and all the fun stuff you want to write home about, anion gaps, all the glory. And then going through, like, here's the basic of cardiac, critical care, pulmonary, nephrology, GI systems. And then we've adopted kind of a hybrid remote and in-person learning, where we really want to make sure that, since we want to focus on your education, that we protect one day a week, which is Tuesday, which is free of clinical responsibilities. And so you have time to sleep, show up, learn, study, and participate in didactics. So every other week we do it in person, usually for 2 hours, right after the critical care fellowship lecture series, the physician fellowship lecture series, which you participate in as well, and then have time to study and blocked outside of clinical medicine. And the other weeks we have assigned lectures and reading to work on, so you can kind of do your own asynchronous work in your own time and space.
Great. Thanks, Matt. And that really takes us to this final slide, which goes over some of our important dates. And I'm going to leave this up here, actually. I'm going to hit hide here on my sharing screen, which hopefully, oh no, it just hid that little box. I actually may escape out of presenter mode just so that I can see faces. And we can have time to put this back up on full screen if that's helpful to people. So let's move on to hearing from you all who are attending briefly. If everyone wants to just introduce themselves and just give us a little bit, just maybe, where you're, where you are in your training or your practice as an APP, and where you're from would be great to hear. But really anything you're comfortable sharing. And I'll just go person by person who I see, and we'll hope that that works. So the first, and I think it's alphabetical. So if your name starts earlier in the alphabet, get ready, which means Abby, looks like you're first. Great. Hi. Thanks for coming on to video. And you are still muted, but when you're ready, you can unmute. Perfect.
Hi there. I'm sorry. What did you want me to say? I'm
That's
Abby.
okay. Yep. Just your name, Abby, and where you are in your education or career as an APP.
So I am a second year PA student at the Duke program and I graduate in August.
Great. Thanks for joining us. Allison Davis.
Hi, can you hear me?
Yes.
Hi, so I am originally from Worcester, Massachusetts, and I'm in my 3rd year at MCPHS Boston, and I'll graduate in May.
Great. Thanks, Allison. Josh Capra.
Hey, good evening. Thanks for having us. I'm actually across the table from Abby right now.
Nice.
I'm a second year at Duke, finishing up in August.
Great. Thanks for joining us, Josh. Katie King.
Hi, everyone. I'm Katie King. I am originally from Madison, Mississippi, and I am currently in my second to last semester. I'll graduate in August of NP school at Vanderbilt, and I'm currently in my trauma ICU rotation. So just a fun little tidbit.
Awesome. Marvel Dunbar. Oh, Marvel, you are on mute. Sorry, I know it's hard. No worries.
I'm originally from Jamaica. I went to Walden. I graduated May of last year, and I took my boards in December. My acute care adult gerontology nurse practitioner. So I'm currently on a travel contract right now, waiting to get accepted to a program. Yeah.
Wonderful. All right, Ryan Piotrowski.
Hi, my name is Ryan. I'm a second year PA student at Wayne State University in Detroit, Michigan, and I graduate in May.
Great. And then I've got Ryan Byron Fields.
Hey, I'm Ryan, second year PA student at the Duke program with Abby and Josh right here, and graduate in August.
Great. All right, Sarah Borgnez. Sorry if I'm not getting the last name right.
You are actually one of the, can you hear me? I'm wearing my headphones.
Yes.
Okay.
Yeah.
You're actually like one of the few people that's ever gotten it right. So congrats.
Thank you.
I am originally from Seattle. I'm actually at Wake Forest right now. I'm finishing up my second year and I graduate in May.
Great. And then Carlos Borges.
Hi. Yeah, I'm a second year PA student at Bryant University in Rhode Island. And yeah, I just started my clinical rotations.
Great. Thank you, Carlos. And actually, we missed an introduction in the beginning. Chris Dyke, I'm so sorry that we overlooked you, but you're next on my screen. So let's have you introduce yourself to everybody.
Hello, everybody. My name is Christine Dyke, and I have the privilege of being the accreditation coordinator for the postgrad program. And I look forward to working with you. The critical care program is amazing.
Thanks, Chris. Next, I have Kayla.
Hi, my name's Kayla. I would turn the camera on, but I'm using the computer at the library and I can't figure it out. I am a second year PA student at Penn State. I'm originally from St. Louis. I'm in my clinicals now and I'm graduating in May.
Great. And then I've got Madison.
Hi, everyone. Sorry, I don't have my camera on either. I'm actually driving into work right now. I'm doing my labor and delivery rotation, so hopefully I'll get to deliver some babies tonight. I am from Pittsburgh, but I go to school in Boston with Allie at MCPHS, and I graduate in May also.
Great. Well, thanks for making it work and joining us on your way in. Olivia Chan.
Hi, I'm from Chicago. I moved to Boston for NP school, so I graduated from MGH IHP in 21. I had to do my clinicals through COVID. Definitely not optimal. Since graduating, I've been working in the ICU as an RN though, but it's a mixed ICU, so we have SICU and MICU patients and multidisciplinary.
Great. Thanks, Olivia. Let's see. Philip Lipsky.
Hi, my name is Philip Lipsky. I'm a second-year PA student at SUNY Upstate out of Syracuse. Currently my rotations are in the Adirondacks, though.
Nice. Snowy, I'm sure.
Very.
All right. Next, we've got Sean Shagru. Oh, all right. I see Sean in the chat. He's saying his microphone isn't working. No worries, Sean. You're in the car driving home, and oh, I've got a visitor on the screen. He says he's from San Diego, and he is a second-year PA student at MGH IHP that's in Boston, and he graduates in mid-October. All right, and then Victoria Dowling. All right, Victoria is not with us. Victoria, if you're trying to talk, you are on mute. Oh, and it sounds like your mic is not working. But she is no, I'm talking. A University of Lynchburg student in her second year and graduates in August. All right, I am going to mute myself and find a home for this little one, and let us start our Q&A. So somebody kick us off with a question.
How often do graduates of this program do they become employed at Dartmouth Hitchcock afterwards?
Yeah, that's a great question. The training doesn't guarantee employment, but we're at about a 50% retention rate. So 1 out of every class that Gemma in our first class stayed in the MICU. And then Amanda in our second class is in the neuro ICU, and Josh in our third class stayed in the surgical ICU. And I think, so I think a lot of that's kind of a balance of choice. Where do people feel like they fit in? What's the FTE availability? And, what unit clicks with them? So we're at about a 50% retention rate.
Awesome. Thank you.
Can you talk a little bit more about the providers that we're paired with on our clinical rotations? Are these providers identified beforehand to train us on those rotations, or are they providers that are on the floor?
So it's dependent on what rotations. The core rotations, we have kind of core clinical faculty. So everybody in the medical ICU on the kind of our green APP team, like our kind of core faculty know about you coming, you're on the schedule, kind of one part of the baked in process. Same in the surgical ICU, that they currently have 3 APPs, and this is kind of a normal expected in the rotation with all of the kind of physician trainees as well from various backgrounds, and the neuro ICU same in the schedule. When you start looking out into some of the electives, it's really reaching out to one of the preceptors in that specialty. So say one of the group of our CRNAs, and it kind of depends on, what's the flow of the operating room and who's going to be there. So we don't have as much foresight of exactly who's going to be precepting you, but it's kind of in all of our units as part of the teaching hospital, and this being, more and more in our APP trainees being more of an established program, just kind of part of the process. So the core rotations, you'll definitely know who's on. There'll be a schedule. You'll be on that schedule. And then in the kind of offsite and, palliative IR, interventional cardiology, should you choose the CVCC or cardiac ICU, those will be identified early and kind of connected before the rotation.
Hey, Matt, can I actually speak to your statement?
Sure.
I actually think, in transitioning from being a student and kind of having a primary preceptor and transitioning into a provider role, I found it to actually be a little bit more helpful to not have a consistent mentor that you've been following every single day, because you kind of learn like different either teaching styles or different like perspectives on patient assessment, or like different ways to present patients, which I think has actually been really helpful for me personally, and just like, reframing the way that you think about something, or like a disease process as well. So.
I have a question for the two current fellows. What does your normal week look like? Like, how many days are you at the hospital versus, I know they said there's one protected didactic day, but just kind of what does it generally look like for you?
So I've only been in the NICU thus far, but my schedule is we're generally scheduled for 4 12-hour shifts a week, and then we have like our one didactic day as well. And the days that we're scheduled, like the 4 12-hour shifts that we're scheduled on service, can be like any day of the week. So it just depends on the week, but I think that's pretty similar to the SICU as well.
I think typically they're in a row if that's possible, but not always.
And I can speak to that just a little bit in terms of your overall schedule. So the majority of your time as a fellow, you're on service in one of the critical care units, and those are all 12-hour shifts. And you can expect that those would be day shifts, and that you would work 4 of those 12-hour shifts a week, and then have your didactic day, which, as Matt mentioned, we kind of alternate. Generally every other week we're in person for our didactic time, and then the weeks when we're not in person, there's a 1 hour of remote lecture, and then additional learning that you would do on your own, which may be watching a video, learning content, or reading articles or chapters in our textbook. So that's really I think that's probably the most consistent like work schedule on what you would spend the most time doing. We do have on our elective and our skills rotations, those tend to be mostly Monday through Friday, more of like an 8 to 5 type of schedule. So those are a little bit different, and they are designed to kind of give you a bit of a break from the 12-hour schedules. And then we have 3 weeks of night shift, so not a whole lot of night shift. And there are ways to incorporate more night shift time if that's something you're looking for. But we wanted to at least have that baseline kind of exposure to night shift.
Thank you.
I had a question for you, kind of in the same vein. For formal didactics, what does that look like? Is there like M&Ms or grand rounds, or I guess what does that look like for your program?
Yeah, Sam and Ellie, do you guys want to speak to that to start, and Matt and I can fill in a little?
Yeah, so they kind of create a syllabus, sort of informational packet, and sometimes that includes some videos to watch. It could be some chapters to read, some key articles to read, and then usually we, come in. We meet every Tuesday, typically at 2 o'clock, and either discuss the readings, discuss the videos, and then sometimes it's case presentations to enhance our learning, or sometimes we are encouraged to teach about the content that we've read about. So it's, or we've got to do a literature review which we have enjoyed so much. But
Absolutely.
seems to be a little bit different each week, which is nice and helpful, I think. Do you have any?
Yeah. And then like included in that, I'll just say like Amelia said, we do attend like the fellow lectures, which are usually like Tuesdays for about an hour. And they talk about like many different topics. Like today we talked about like airway obstructions and there's been like open abdomen. There's just been like a lot of different types of lectures that they do there. And then generally, if we are on service, we will also go to like the hospital medicine M&Ms on Wednesdays as well.
Yeah, so the hope is to have a contained didactic series within the fellowship itself that covers all the broad base of critical care. And I think we're fortunate and intentionally partner with the critical care physician fellowship. That's thankfully a multidisciplinary fellowship. So there's another 2 hours of didactics that happen at 12:15 on Tuesdays and Thursdays. That the Tuesdays have a cycle of morbidity and mortality, problem-based learning, journal clubs, and then just general topic presentations that the fellows put together. And then the critical care physician faculty on Thursdays kind of present areas of their expertise, whether they're acute care trauma surgeons, interventional pulmonologists, nephrologists, talk about critical care and obstetrics, some of our neuro folks. So kind of spanning the spectrum of critical care. So at least 4 hours a week, and then layering in the medicine when available.
And what
Awesome.
I'll add,
Thank you very much.
yeah, and the only thing I would add to that is that all of this stuff is CME accredited. So, as you move through like, your licensure and things like that, we all have CME requirements, and you would leave your year with us with more than enough to really maintain your licensure. Even if, like, I know for PAs we're on a 2-year cycle, and APRNs, I think it can vary, but you would obtain all CME through the available didactic content, which is really nice, and is something that's really important to us. So there is really a wealth of learning opportunities, and I think the critical care focus stuff is the physician fellowship teaching, and then layered on that and integrated with it is our APP fellow teaching, which is really our touch point to kind of like get the specific learning that we feel like is really important to our curriculum in. And that's 2 hours in person every week. Usually it's me and Matt, and we pull in other APPs from the different specialties, along with Ellie and Sam. And we've had actually one of our internal medicine APP fellows has been joining us for that lecture content as well. So it's a good group.
Awesome. That sounds really unique. Thanks.
Are there any opportunities to attain any certifications during the program, like ATLS or FCCS or anything?
So that's a good question. The one that we do invest in is ENLS, Emergency Neurologic Life Support. We have tried in the past, and it's still a potential option to do ATLS, but we have not been able to have the space in that training up to this point. The other certification that we do move our fellows through is the Yellow Belt training, which is really about quality improvement in healthcare settings, and is, while not clinically, it's not like sort of like clinical teaching, but it is really relevant to ongoing practice. And so that is something that we do. Yeah, good question. And then ACLS and BLS are offered free through the hospital. So if somebody, sometimes our folks come in already certified, but if you need to renew, that's also offered. Yeah.
So I know that it said the start date is kind of contingent on the fellows states. What does that look like with having to pass boards and study for boards, especially if you graduate in like August?
Yeah, we're flexible. Ellie, do you want to speak to that at all?
Yeah, I'd love to. So I graduated from PA school in August this past year, and then I took my boards, I think, in September, and then like started the process of getting my New Hampshire license, which I would recommend doing early. Um, but yeah, basically, like I just worked with Amelia and we just kind of had to like keep adjusting my start date based on when everything got approved. But everyone was like super accommodating about it.
So it is important to us that our APP fellows start on a similar schedule. And as Ellie mentioned, like she and Sam are probably, I think it's just 4 weeks offset, which is very, we can accommodate that. And Ellie was also accommodating in attending some of our orientation lectures before she had officially started. So, we like to have, because it's important that we squeeze all this didactic content in, we do need our APP fellows to start on a similar timeline, but we do have some flexibility. And because all of our APP fellows are fully licensed providers, we just have to be flexible with the state licensing board, which can be very inflexible in their timeline. So we have ways to work with that. Yep.
I was wondering, do you guys have opportunities to learn how to do more ultrasound or anything like that?
Yes, that is developing in the medical center and physician fellow space, where in the last few months we've kind of moved to being able to record more and getting the both physician fellows and all of our critical care APPs within a kind of being able to record and invited to the didactic series. So that's been a kind of continued development that everyone is welcomed, and we want to make sure that there is some core ultrasound training to launch you into your first job. I think what I have learned that orchestrating this for the fellowship in the ICU has been, it just takes a while. So Sam and Ellie haven't hit the kind of full what that means, but I think the overall plan to layer in and what we're hoping to develop in the next kind of 3 to 6 months is baseline ultrasound knowledge, some didactic learning, some hands-on learning about the basics of kind of thoracic, cardiac, and procedural knowledge, and then seeing it layered more and more in and intentionally with some image review at the bedside.
And then we do start out with just like a very basic and foundational intro to ultrasound through an online learning modules called SonoSim that go through kind of all the different body system ultrasound modalities from sort of like an EM critical care focus. And so that's where we start. And then, like Matt said, layer on, formal didactic teaching with bedside teaching. And as you guys have probably experienced as students and practitioners, there's a wide variety of comfort with ultrasound among experienced providers too. So that exists here, at the bedside, but our goal is definitely to provide some baseline kind of didactic ultrasound because it is so integral to critical care.
I think our hope is when you graduate, we can have a clear statement of what your kind of experience and proficiency is. So similar to, we wanted to be intentional about having every conference count for CME for licensing and credentialing in the future, that we've kind of built in my kind of other educational role in the ICU, kind of built ultrasound CME, and then within the software we use, we can also count how many scans you've done. So we can, at the end of graduation, can spit out you've done, so and so many scans that, here's, and using like the SCCM ultrasound metrics as a benchmark. But I will, I'll cap it there. We can just keep going about what education landscape and all that stuff looks like later.
Thank you so much.
Yes.
Can you talk a little bit more about some of the benefits that are included in this position, like stipend, conference days, any PTO allotments or anything like that?
Yeah, so salary lands at just over $70,000. And that includes 4 weeks of vacation. We have our APP fellows take 3 during the fellowship, and then their last week gets paid out when they're done. And we do track like sick time. Our fellows have been just really pretty, like, there haven't been a lot of issues with that, but at a certain point, there we would need to have like makeup time for illness if there was extended illness. And so that's what really like PTO and pay look like. And then you had asked about conference days. We don't have, because so much of the fellowship is like focused on your learning. We want all of your time to like curate that. So unfortunately, we don't have any conference time or like CME funds built in, because we're kind of providing that educational landscape for you. And then Holly Ann or Bailey, I don't know if you guys could speak more to the hospital benefits. The other thing I would say is that during our interview day, we do have somebody from HR who can speak specifically toward like is included and what that benefit looks like and things like that.
Yeah, and I can drop the link to our financial and benefits information into the chat as well, so that you guys can check it out. But you are fully licensed providers, so you get all the same benefits that any other provider would get. So medical, dental, vision, all that jazz. There's no limitations to that. I think the only thing you don't get that any other provider would get is, as Amelia mentioned, is CME dollars. So, but otherwise, all that is offered to you. I think the only other thing that just popped into my head too is tuition reimbursement, because you're only here for a year. So, and you're in an educational program, so you wouldn't be eligible for that unless you then became a full-time employee after the program. I will drop the benefits info in just a second into the chat.
I'm not sure if it was mentioned, but what's the time frame each rotation? Like, how long is it, like, between the different specialties?
Yeah, I can speak to that, Marvel. We haven't talked about that yet. So we I think are predominantly MICU based in terms of our time. So our orientation takes place in the medical ICU. That's 5 weeks long, with the first week really being taken up by like hospital orientation. And then we have another 2 4-week blocks in the MICU. Actually 3 4-week blocks in the MICU. So that takes your MICU time up to 17 weeks, plus another 3 weeks of nights. So 20 weeks in the medical ICU. And we really feel like the medical ICU is where you get those like foundational critical care skills that you would really need, even if you were going to work in a more specialty ICU. And then there are 8 weeks in the surgical ICU, 6 weeks in the neurocritical care unit. We have a pretty small cardiovascular critical care unit. So that's one thing I would say about our program, is that if your passion and interests are in cardiovascular critical care, just knowing that we don't have as significant of a degree of exposure to that environment, and our cardiovascular critical care unit doesn't do like a high volume of assist devices, and we don't have a heart transplant program at Dartmouth Hitchcock. So 2 weeks in the cardiovascular critical care unit. And that really covers kind of the critical care time. And then we do 2 weeks of airway, which is really just intubating OR patients and working on airway management skills in addition to intubation there. 1 week with interventional radiology and 2 weeks with palliative care. So those are the time breakdowns. And then we have that leaves space for 4 2-week long electives. And those really vary and usually align a lot with the medical specialties. So we've had people do cardiology, rounding with the cardiology consult team. We've had people also do like some time in the cath lab and nephrology, infectious disease, things like that. Any questions that raises, hearing all of that detail?
I think you pretty much covered everything that I was thinking about. Thank you.
Mm-hmm.
I have a question. For those of us who are still in school, what can we be doing during our clinical year to make us as competitive as possible for when we do apply for this program?
Yeah, that's a great question, Carlos. I think just when we read through applications, we really look for, some sort of through line that indicates an interest in critical care. And that can be hard to find. And so, I think just trying to find clinical experiences that will be in critical care is really, I think, the thing that that we like to see the most and that you can do to prepare yourself. Yeah.
So that would be like trying to get as many rotations as possible in ICUs.
Yeah. Yep.
Yeah.
Definitely.
Or rotations, and if not rotations that abut the ICU, because I think it's helpful to have, what does being in an intensive care mean, and having experience with that and that kind of both life, what topics you deal with, and the thought process that goes into it.
Very good. Thank you so much.
I have a question that kind of goes along those lines as well. After somebody is accepted, what do you find makes like a really successful fellow in your program specifically?
That's a great question. I think really just kind of personal drive and motivation to engage with the learning opportunities would be the number one sort of characteristic that we see in our most successful fellows. And I think, people who have a high degree of confidence in their knowledge of kind of both physiology and pathophysiology of disease. And we engage with kind of evaluating that a little bit in our interview day with a case review. And so we do look for that, because I think that's a skill set that you really need in critical care, is that sort of baseline knowledge and confidence in that knowledge as well.
Thank you.
Sure. Yeah. And Matt, I don't know if you'd add anything to that, any glaring omissions on my part there.
No, I think a lot of it is you're interested, you're leaning in, and we get it. It's hard. I think it's hard learning a new skill and being pushed every day and coming back and taking it kind of one step at a time and being able to engage with a process.
And actually, Ellie and Sam, I'd throw that to you guys too. Like in your first weeks and months, where do you feel like you're leaning? What skills do you feel like you're leaning on the most and or developing the most?
I feel like it's been interesting, and I think this is probably maybe the difference between Ellie and I, but I previously worked as a nurse, so I think I initially was relying really heavily on just like reverberating data, and that's, I think, what nurses have been trained to do, but really like, altering your knowledge and assessment to make like clear interpretations of what's actually happening with the patient and being able to like objectively back that statement up, I think has been a learning process for me. But I think it's ultimately a strong skill to understand, maybe as you're like planning for interviews.
Yeah, I had very little critical care experience when I started. And I think a lot of what I relied heavily on was like a lot of practice that I got during my rotations, like on rounds presenting patients, and like really have like from that been able to like develop like assessment and plan from that. And then yeah, I think like there's a lot of skills that I'm working on still, but I think that everyone is like really like it's a very supportive environment and like people are really willing to teach you, and I think like just being curious and interested and like showing that is important.
Oh, you guys are awesome. Thank you.
How do you evaluate your fellows throughout the program?
Yeah, great question. So, at the end of each rotation, our fellows are evaluated by the faculty that they worked with. And Ellie and Sam have been on along the ride for us in our journey to using MedHub, which is what our physician residents and fellows use for evaluation. So this has been an exciting year to migrate to that, but there's also been kind of just a curve. And Christine Dyke, who you met earlier, has been our champion, kind of helping us set that up. So that's the software program that you really interface with to select who evaluates you after your rotations. And so the faculty you've worked with will fill those out. And then those actually get mapped to our core competencies. So we use a milestone based competency kind of evaluation system, which is what GME, so physician, fellow, and residents are evaluated on as well. And we've chosen that really to align with graduate medical education on the physician side. And so every quarter, you sit down, our fellows sit down with Matt and I individually. And we then take the aggregated evaluations from the faculty they've worked with and use those to basically show where they are on the different milestones, moving basically, from novice to experienced provider. And so that is how we track progress. Those are the core like competencies and goals of our program. And I think we have somewhere like about 13 core competencies that we work through and evaluate people on. And those are awesome. Those are really like, I think are a roadmap to your professional development and provide like, kind of reach goals and, where you need to be at a baseline, kind of a full spectrum. And our graduation target is like a competent provider, which really sits like right in the middle of that like career progression pathway that the milestones lay out. And then procedures are also evaluated, like every procedure that's done gets evaluated by the provider who is observing you or assisting you in that procedure.
And our hope is this is a transparent process from the beginning. You're given your exactly what is expected. Here's what you will be seeing, and then that's what that's the bar you're held up to.
Awesome, thank you.
I would like to know what system do you use your EMAR?
Epic.
Some information.
Okay, great.
I just have one more question. I know that for the elective rotations, one of the opportunities is to do pre-hospital transport. I was just curious as to what that entails.
Well, that is contingent on the hiring process and availability for ride along time, which has been limited recently just due to DART's availability. But with the hope is to have kind of the elective rotation is written out with the hope of experiencing what it is to do critical care transport, which is seeing both rotor wing and ground transports from both scene and interfacility hospitals, whether they're medium, small community hospitals, critical access hospitals coming to tertiary care centers. And, the hope with that is to both see acutely ill patients that are usually very early on in their disease process, understand where people are coming from, that if an emergency department that has, 5 rooms, 1 doc or APP and 2 nurses is different than what we have at Dartmouth. And then also to balance, how do you use skills that, they talk about crew resource management and communication in high stress, fast paced environments, along with layering in medical knowledge. So those are the goals of what the rotation is set up for. The issues we've had thus far is just with the overlapping early on in the pandemic of just ride time stopped. And then recently it's been just kind of a limited resource of trying to balance, 2 weeks of dedicated time when they're not training new pilots or new crew members. But that's the idea of the experience.
Thank you.
Any final questions about the application timeline, interview process, anything like that people want to know?
Yeah, I was wondering, you guys mentioned a couple times that you get to learn how to do procedures. What kind of procedures did you guys learn or have the opportunity to learn about?
Yeah, Sam and Ellie, do you guys want to speak? You guys are obviously in the first quarter of your training, but I think you've probably both had some good exposure to procedural opportunities so far.
Yeah, so I think it just depends. There are like listed procedures that you do get to go through, but I think since, like Amelia said, we're kind of early on in our training, we obviously haven't done all of them. But like some things that I've done are like put in arterial lines, put in central lines, do like chest tubes, put in like a PA cordis, and I've loaded a swan. I don't want to brag, but I did intubate. And we also do like bronchoscopy.
Yeah, the hope is exposure to all the critical care procedures. I think the ones that we really want you to leave our program knowing are kind of core management of how do you do vascular access, paracentesis, thoracentesis, and then, when available, more hands-on experience with chest tubes, and then intubation and kind of the foundations of bronchoscopy. And then depending on, what time procedures are available, lumbar punctures, pulmonary artery catheters, transvenous, transcutaneous pacing. But so the gamut of critical care procedures with a lot of the focus on the rare ones are more rare, and vascular access and ultrasound guided procedures are kind of the bread and butter in what we do.
And I would say like 2 things make our program unique. One is, as all of our critical care units are pretty independent in providing their own procedures. So unless there is a very compelling reason we are not having procedures performed by interventional radiology, So that is, I think, unique, doesn't exist everywhere. And the other is that we have a pretty highly trained and experienced critical care APP staff who are not looking, who are skilled at teaching and want to create that opportunity for our learners. So I think those are real positives for procedural experience.
That all sounds amazing. Thank you.
I think you're muted, Amelia.
Yeah.
Oh, sorry, just blabbing away to myself. I was just saying our website and then the contact on the website, which really gets you hooked into Holly Ann and her team, are always available to you guys, and you could reach out to me directly as well if you have any questions. Please don't hesitate, and we really appreciate your interest and your time. And thanks to those Sam and Ellie in particular at the end of your shifts joining us, and Matt also. Thanks everybody.
Thank you very much, Mary, for your presentation.
All right, and I think we'll have folks sign off unless anyone has any more questions.
Thanks, everyone.
Thank you.